Thank you very much. This is my pleasure and honor to be able to present this abstract on behalf of my co-authors of impact of socioeconomic factors on access to and outcomes of allogeneic transplant for patients with AML. This is my disclosures. So I'd like to start off by introducing the concept of social determinants of health. These are conditions in which people live and work that affect their health. They can occur at the individual or area level, such as neighborhood, city, or county, where they're called social risks, and societal level. But why is this important? Well, there's a well-established negative association between social determinants of health and poor survival outcomes and access to therapy in oncology and solid organ transplantation. However, less is known about the impact of social determinants of health, survival outcomes, and access to allogeneic transplant, the only potentially curative therapy for AML patients, highlighting a critical gap in knowledge and emphasizing the need to identify actionable areas to improve health disparities. To the best of our knowledge, this is the first study to prospectively evaluate the impact of specific social determinants of health on the following outcomes: mortality without transplant, receipt of allogeneic transplant, and mortality after transplant. So the study design was a multi-center study, prospective observational longitudinal study, dating from the start of AML therapy induction. Enrollment period was between July 2013 and December 2017 across 13 US AML treatment centers with a median follow-up of 54 months. So we looked at 4 key social determinants of health domains at 5-digit zip code level. These domains represent both general social risk as well as specific social risks. So we looked at area, income, and education, which included median household income, percent of adults over 25 without a high school diploma, percent of households living below the federal poverty level. We looked at area assistance program use, percent of households receiving Supplemental Nutritional Assistance Program, or SNAP, previously known as food stamps, and Supplemental Security Income, or SSI. We also looked at area housing instability, or percent of homes where more than 30% of income was spent on housing, and percent of homes with a second mortgage or home equity loan, as well as area transportation, or percent of people who drive to work alone. We previously conducted analysis to evaluate the impact of patient-specific and disease-specific characteristics on things like mortality without transplant and access to transplant. And those with most notable associations were used here as adjustments. We also adjusted for quality of life and frailty measures. The model for mortality after allotransplant, we did not adjust for quality of life and frailty in order to avoid the impact of allotransplant on these measures. So this is patient characteristic table. We had 692 patients. Large proportion of patients were older, over 65, with a significant comorbidity burden, and as seen here by augmented HCT over 4. However, they had a pretty good performance status, as seen here by Karnofsky performance status, over 70. Ethnic and racial composition of the study population was mostly white and non-Hispanic. And the AML variables for our study population, mostly newly diagnosed AML, with a smaller percentage of patients with relapsed refractory AML or high-risk MDS. So ultimately, 46% of patients received allogeneic transplant. And before we get to the results of the analysis, I'd like to clarify how the outcomes were modeled. So each line here represents a separate social determinants of health factor to determine the association between social determinants of health and the outcomes. These were modeled independently in the multivariable models. And the adjustments in these models were listed down below the forest plot. All social determinants of health factors are modeled as continuous linear variables with corresponding hazard ratio presented in terms of increase in income of 25,000 and increase in other variables in other factors in 10%. So this outcome is essentially showing the impact of social determinants of health and mortality before patients receive transplant or without transplant. So what we saw here is that as social risk of the neighborhood increased, as seen here by reliance on government assistance program use, living below the federal poverty level, or high percentage of patients with low educational attainment. Those patients were more likely to die without transplant. The association was particularly strong for patients on government assistance programs such as SSI, with adjusted hazard ratio of 1.4, and for neighborhoods with high proportion of patients with less than high school education, with adjusted hazard ratio of 1.24. And this is our next outcome of receipt of association between social determinants of health and the receipt of allogeneic transplant. So adjusted hazard ratio below 1 signifies less chance of receipt of transplant. And so what we saw here was a similar trend. As there was increase in social risk of the neighborhoods where patients were coming from, such as reliance on government assistance programs or low educational attainment, those patients were less likely to receive transplant. As seen here by, for example, proportion with less than high educations with adjusted hazard ratio of 0.7. And this is our final outcome where we looked at association between social determinants of health and mortality after patients receive transplant. So while several social determinants of health factors show a trend towards increased risk of mortality after allotransplant, none of the associations were strong enough to draw definitive conclusions. So this finding suggests that once patients are able to overcome the barriers and receive allotransplant, the outcomes could be comparable regardless of their socioeconomic backgrounds. However, further research is needed to validate this observation. So in conclusion, to the best of our knowledge, this is the first study to prospectively evaluate the impact of specific social determinants of health on the receipt of allotransplant, as well as survival outcomes. Area-level lower education and higher surrogates of poverty seem to be associated with not only the reduced chance of receival of transplant, but also higher risk of mortality without transplant. So for patients who receive allotransplant, these socioeconomic barriers have a less pronounced effect on mortality. This highlights the importance of promoting equitable access to allotransplant, which could help level the playing field for AML patients across diverse socioeconomic backgrounds. By breaking down these barriers, we can ensure that life-saving therapies are available to all patients, regardless of their circumstances. And this is my acknowledgement slide. Thank you very much.
Great. Thank you, Dr. Velucci. So this concludes the presentation.